Assalamu alaikum, dear participants and respected panelists, especially our today's speaker, Dr. Kabiruzzaman sir, and as usual, our respected panelists, Sir M. Nazir Islam sir, Chowdhury Ahmed sir, Professor Saiful Islam, and from Malaysia, Dr. Saroi Ranjan Rajgopal, also our chairperson, Dr. Abdul Chowdhury. Today's topic is different. From our student life, we not hear the term is grown up congenital heart disease, but which is now it is well accepted terminology. Lots of, I think, guidelines also which in published in the ESC. Why which? I think 80 to 85% is now congenital heart disease grown up to the adult life. So it is different topics terminology. Which today's I think the right person to talk about the ventricular septal defect, Dr. Kabiruzzaman sir. Welcome in IPDI. Thank you, sir. Wadud sir, please your comments.
Assalamu alaikum and good afternoon, everyone. And today we are going to talk about grown-up congenital heart disease, which itself has become a subject in the sense that many of the congenital heart disease patients, they are being treated quite nicely in their childhood, but still some are not getting the proper treatment in childhood. They're going and getting older with the persistence of that defect. Again, some are getting treated, and post-treatment there are certain changes in the heart. They may be permanent, or they may create certain other problems. That also comes into under the context of grown-up congenital heart disease. And for that reason, for a child, the approach, and for a grown-up patient, the approach, there are certain differences. And most of these approaches are dependent on the echocardiographic finding. So obviously, none other than Professor Kabiruzzaman, who is here, who has made his name the field of echocardiography, is one of great excellence. He'll be talking about this, and we do hope we're going to learn, as usually, many more things from him. And for the fellows, young fellows, I do think they'll be enjoying the session. Welcome you all. Professor Kabiruzzaman sir, you can start now.
So please unmute, sir.
Unmute karen. Please mute everybody except the speaker.
Are you audible?
Yes, sir.
Yes, sir.
Thank you, Professor Wadud, for so many kind words. So, respected teachers and chairpersons, moderator, and the panelists, and the distinguished audience. My topic is ventricular septal defect. I have conducted this lecture actually to keeping in mind the fellows. Actually, this lecture is for the novice, how to identify the VSD, how to diagnose the VSD. Actually, I will concentrate my talkings regarding okay. So I'll talk on the ventricular septal defect. So I have constructed my lecture regarding the definition, incidence, prevalence, anatomy of the interventricular septum, classification and type of VSD, how to measure the size of the VSD, malalignment of the VSD, how to evaluate it, and mechanism of spontaneous closure of the VSD, pathophysiology, Cli Feature management. But I highlight the colorful one. I have taken the anatomy of the interventricular septum as because during my learning period, I faced that if one can understand the perfect and meticulous anatomy of the interventricular septum, then it is easy for him to identify the VSD and to classify the VSD and to type the VSD. So definition is the ventricular septal defect is a hole or multiple holes in the interventricular septum. And you can see the diagrammatic picture. This is the ventricular septum. This is the ventricular septum. This is the ventricular septal defect. And this is the patch closure of VSD. And it was first described on an entity by Rozier in 1879. At that time, he did not know that this murmur, this musical murmur comes from VSD. And after his name, it is also known as the Malalignment of Ventricular Septal Defect. So VSD is the most common congenital anomaly, and it may be an isolated defect or part of a complex malformation. But there are other literature that say that prolapse of the mitral valve is most common. Some literature says the bicuspid aortic valve is most common. So these are the incidence or prevalence of the congenital heart disease. You see among the list at the top is the ventricular septal defect. The list is among the more than 1 lakh patients. So incidence is 2 per 1,000 live births, and male and females affected equally. But there is some variation. You can see here, the VSDs are slightly more common in females, approximately 56% female and 44% male. So regarding the etiology, these are the congenital, ischemia, iatrogenic, traumatic. Among these, congenital is the most common. Regarding ischemia, it is usually due to post-infarction, iatrogenic, following cardiac surgery and pacing, traumatic, a direct blow to the chest is the most common mechanism. And so VSD may be isolated or primary, or VSD may be part of another cardiovascular anomaly, such as complete atrioventricular septal defect, GORV, truncus arteriosus, and tricuspid atresia. Actually, VSD is obligatory for life-saving for these complex congenital heart diseases. So, the types of VSD, what are the types? It depends on the location, size, pressure gradient, alignment of the different parts of the interventricular septum. Regarding the location, it may be perimembranous, outlet, inlet, trabecular. Size, it may be small, moderate, large. Pressure gradient wise, it may be restrictive or unrestrictive, and there may be malalignment. I will discuss each and every component in different sections. So first, I have told you that I want to recapitulate the anatomy of the interventricular septum. I am keeping in mind the philos. So regarding the shape of the interventricular septum, it's a complex shape. So need multiple cross-sectional echo images for complete understanding of interventricular septum and the ventricular septal defect. So you can see the parasternal four-chamber view, apical four-chamber view. It is a curvilinear structure. It is concave in the perspective of LV and convex in the perspective of RV. But there is alignment between the interatrial septum and the interventricular septum. If you see the short axis, it is convex from RV side, from a concave from LV side. And if you see from apex to RVOT, it is a curvilinear structure. And if you see the apical long axis view, you can see this is the from apex to LVOT. This is a curvilinear structure. And you can see the short axis at the great level view, great vessel level. Then you can see this is the interventricular septum outlet part. This is the LVOT, this is the RVOT, this is the pulmonary valve, this is the tricuspid valve. So this is a complex shape. Now, morphologically, the interventricular septum is composed of membranous septum and the muscular septum. Again, this membranous septum may have two parts atrioventricularis and parts interventricularis, and muscular septum have three regions: inlet portion, trabecular portion, infundibular or outlet septum. I'll show the picture of the things. And this, regarding the muscular septum, it is the radiating out from the membranous septum like the spokes of a wheel is the muscular septum, and typically divided into three regions. What are the three regions? If you consider this diagrammatic picture, it is the RV wall is remote, This is the membranous part of the IVS. So this is the inlet part, trabecular part, outlet part. These are radiating from the membranous part. Actually, these three portions develop from three sources. Actually, outlet septum developed from conal crest, trabecular septum from the primitive interventricular septum, and inlet septum from the AV canal cushion. So all that develops and then unite at the membranous part. So what about the membranous part of the IVS? Actually, this is a relatively small structure, measure only 5 millimeter in diameter in adult, bounded superiorly by the aortic valve and inferiorly by the muscular septum. If you consider this picture, it is the morbid anatomy, diagrammatic. And you can see this is the membranous part of the IVS. And this is the RCC, this is the NCC, this is the septal leaflet of the tricuspid valve. This is the trigon. So the part of the interventricular septum that is in direct contact with the RCC NCC junction, septal leaflet of the tricuspid valve and trigon. That is the membranous part of the IVS, and these landmarks will make you sure that you are identifying the defect in the membranous part. It's important. And so, I have talked it earlier, the membranous part have two parts, pars atrioventricularis, pars interventricularis. What are these? If you see this picture, this is the membranous part of IVS, and this is the aortic valve, this is the septal leaflet of the tricuspid valve. So, part above the septal leaflet is the pars interventricularis, pars atrioventricularis, and this is the pars interventricularis. So if you see the morbid anatomy, this is the membranous part of IVS that is in direct contact with the aortic valve and septal leaflet of the tricuspid valve. And this is the membranous part that is attached to the crux of the IVS, crux of the heart. So if you see from the sub-costal view, this is the membranous part. This is the interventricular septum, and this is the aortic valve clasp, and so the direct contact is the membranous part of IVS. And if you see the diagrammatic picture of the short axis view at the great level of the echo short axis view, this is the membranous part of the IVS because it is contiguous with the septal leaflet and the junction of the non-coronary RCC and NCC. And so in the real 2D images, short axis, great level, this is the tricuspid valve, septal leaflet, the pulmonary valve, this is the outlet septum, this is LVOT, this is RVOT, this is the membranous part. And if you see the apical 5-chamber view, this part is the membranous part. It is contiguous with the septal leaflet of the tricuspid valve and the cusp of the aortic valve. So what are the inlet part of the IVS? Previously, I have talked about the membranous part. Now I will talk about the inlet part of IVS. So if you can see the apical 4-chamber view, this is the part of the IVS that lies in between the atrioventricular valve. That is, this is the inlet part of the left ventricle. This is the inlet of the right ventricle. So the part of the IVS that separate the two inlet part of the ventricle, that is the inlet part of the IVS. And so this is what is the extent of the inlet part of the IVS? Actually, it is the apical end of the anterior mitral leaflet. This is the extent of inlet part of the interventricular septum. It is just below the AV valve and up to the tip of the anterior mitral leaflet. And so this is another concept. This portion is known as the atrioventricular septum of the heart, because this part develops from the endocardial cushion. It contains the inlet part of the interventricular septum and the primum part of the interatrial septum. Now I will talk about the outlet part of IVS. So this is the diagrammatic picture of the echo, long axis and short axis. In long axis, the part that is contiguous with the aortic valve, that is right cusp of the aortic valve, that is the outlet part of the IVS. And the part of the IVS in short axis, this is the RVOT, this is the LVOT, that is direct contact with the close to the pulmonary valve. This is the part that is the outlet part of the interventricular septum. And so in the classical long axis view, the part of the echo, it is the part of the IVS that is close to the or contiguous with the aortic valve. That is RCC, it is the outlet part. And if we go for the long axis RVOT view, this is the part adjacent to the or contact to the pulmonary valve, that is the outlet part. So it is the another diagrammatic picture showing the membranous part and outlet part in short axis. And so this is the echo short axis view. This is the part, echogenic part is the outlet part, short axis view, and this is the membranous part. So this is the diagrammatic picture of the LVOT. So this is the tricuspid valve leaflet septal. This is the pulmonary valve. This portion is the outlet septal. This portion is the outlet septal. So I will talk now about the trabecular muscular part of IVS. So this is the part of the interventricular septum, that is the trabecular muscular part. And this is the outlet part, and this is the trabecular muscular part. This is the parasternal long axis view of the echo. And regarding the fourth chamber view, the part beyond the inlet part, this is the inlet part, so and it is the trabecular muscular part. And regarding the short axis view, this is the morbid anatomy. And you can see this is the trabecular muscular septum. Here, for ease of description, this muscular part again have divided into three parts by imaginary plan. On these two imaginary plan, this divides into anterior portion, mid portion, and posterior portion. It is divided for ease of description for localize the VSD. I will describe it in later slides. So the same thing is echo picture I have shown is the anterior portion of the trabecular muscular septum, mid portion, and the posterior portion. And so in the conglomerate view, you can see all the black things in parasternal long axis view, short axis view, and apical 4-chamber view, 5-chamber view. These are the trabecular muscular septum. One thing is important, you will never find any part of the trabecular muscular septum at the level of the great vessel short axis view. So we have talked about the different parts of the IVS. Now I will go to the type of VSD. It will be easy now to understand for the types of VSD. So according to the location of the IVS, VSD may be muscular VSDs or membranous VSD. This is one of the thought. They have divided it classification according to location and margin of the VSD. They mean the muscular VSDs like margin is bordered entirely by myocardium and can be trabecular, inlet, and outlet in location. And another sense, membranous VSDs, but these are not synonymous to perimembranous VSD. These are bordered in part by fibrous continuity between the leaflets of the AV valve and an arterial valve, often have an inlet, outlet, and trabecular extension. The thing is that these muscular VSDs are easy to repair by surgery and is suitable for the device closure. But these are not amenable or not suitable for a device closure, and it is tough for repair. This is another classification, according to the location. This is perimembranous muscular doubly committed sub-arterial inlet septal ML alignment. I will discuss each and every time in separate slides. And perimembranous VSDs can have subtypes according to the extension, inlet, anterior, or outlet. Muscular also have a subtype, outlet, trabecular, inlet, anterior apical, like this. So perimembranous VSD is the most common, is the 80%. Conal septal or sub-arterial doubly committed defects are 5 to 7%, and inlet defects are 5 to 8%. So another method of classification that was previous initial days that was used, they used using the supraventricularis Christus supraventricularis as the landmark. VSD can be divided into supracristal and infracristal. You can see this is anatomy. This is the right ventricle. The free wall is removed. This is the supraventricular crest. So any defect that is located superior to this crest, that is the supracristal, and any defect that is located below this crest is the infracristal. And if you consider the short axis view at the great vessel level and mark an imaginary plane, the area that is left to this plane, that they are supracrystal VSD, and area that right to this plane, or that those are the infracrystal VSD. Now, if there is someone who can understand the interventricular septum by subcostal views, don't be afraid of. I'm talking it like this is a morbid anatomy. You can see that there are different section. If you go this cross section, you will go to this view, and you will go this LVOT view. This is the trabecular muscular part, and this is the membranous part of IVS. This is the aorta. And if you go this plane, you will get RBOT. This is the, you can identify the outlet muscular VSD in this view. And this is the trabecular part, this is the outlet part. More rightward, more towards the apex, you will get the all are trabecular muscular part. But beauty of this view, the apical muscular VSD not be negotiated from transthoracic view. Then sometimes the subcostal views may help. So on the basis of location, again, I'm repeating the perimembranous, outlet VSD, inlet VSD, trabecular muscular VSD. So regarding the perimembranous VSD, how can it be identified? I think there are some synonyms, including the perimembranous VSD. Someone, it was written in different literature, the membranous defect or infracrystal defect. Nowadays, these are not used in textbooks or literature. So how can we identify the perimembranous VSD? There are some landmarks. Those which are landmark, it is situated in contact with the fibrous trigone, therefore in direct contact with the tricuspid valve at the commission between the anterior and septal leaflet and aortic valve. For easy memory, it is just keep it. The VSDs which are in direct contact with the septal leaflet of the tricuspid valve and the non-coronary cusp of the aortic valve, that is the perimembranous VSD. And see, this is the location of the perimembranous VSD. I'm repeating this anatomy. It is located in contiguous with the septal leaflet of the tricuspid valve and the right coronary and non-coronary cusp of the aortic valve. And this is in 5-chamber view. 5-chamber view. This is the perimembranous part of the location of the perimembranous VSD. It is in contact with the septal leaflet of the tricuspid valve and the right cusp of the aortic valve. And for the echocardiographic view, this is the parasternal long axis inlet view. Mind it, pure perimembranous view, you will not find it in classical long axis view. You have to tilt it towards the right ventricular inflow, then you will get the defect in this location. And this is another subcostal view, 4-chamber view or frontal view. You can see this is the location of the VSD that is in contact with the septal leaflet of the tricuspid valve and right cusp of the aortic valve. Now, perimembranous VSD have some subtypes. I have told it previously that it may extend in different ways. That it may have perimembranous VSD with outlet extension, trabecular extension, inlet extension, or extension to all the parts having the very large VSD. And you can see this is the diagrammatic picture. This is the perimembranous part of the VSD, and it may extend toward the outlet part, trabecular part, inlet part, like so. So this is the picture, short axis view at the great vessel level. This is the location of the perimembranous part, perimembranous VSD. And this is the still picture showing 2 VSD jet of closing VSD. I'll show the video. So you can see here, there is 2 VSD jets, one from LB to RB, another from LB to RA. These are found in the mostly those the VSD are getting closed by septal leaflet of the tricuspid valve. So I'll talk now about the defect, the outlet VSD. Obviously, the defect that involve the outlet part of the IVS, that is the outlet VSD. And outlet VSD have some eponym, or like someone calls the supracrystal VSD, Infundibular VSD, Conal VSD. But these subpulmonary and doubly committed sub-arterial VSD have some different description. I will talk it later on. So VSD can be, outlet VSD can be described in more precise way and such that it may be outlet muscular. That is the bordered entirely by myocardium. These are the VSD may be amenable for device closure. An outlet VSD that is in part by fibrous continuity of the aortic valve and other parts by myocardium. And subpulmonic outlet VSD, doubly committed outlet, doubly committed sub-arterial VSD. Mind it, this is doubly committed sub-arterial, not sub-aortic. So this is the location of the outlet VSD. I have marked it 11 o'clock, 12 o'clock, 1 o'clock. It is, there are some literature they have described. As for example, this is the LBOT, if you think it as an clock. And this is the RBOT. Then any defect that is confined to this location, you can describe it. There is defect involving the outlet part at about the 12 o'clock position of the LBOT. Then your description will be precise and surgeons can easily identify the location in spite of searching the whole things. So you can describe it like that. It is located at the 1 o'clock position of the LBOT. So in classical parasternal long axis view, if you find any defect in this location, that is the outlet VSD. And if you don't find this and you have to tilt it towards the RBOT inflow view, then that is the perimembranous VSD. So this is the classical side of the outlet VSD. And you can see the parasternal long axis view. This is the VSD, outlet VSD, parasternal long axis view. And you can see this is the outlet VSD, but there is some prolapse of the right coronary cusp of the right cusp of the, that is RCC, right cusp of the aortic valve. I'll show the video, then you can understand it. You can see this is the VSD, and this the right RCC is prolapsing through the VSD and obstructing the VSD flow. And this is the omni of size, and this patient have air. So you can see that how is the prolapse. I can remember. You can see this is the prolapse of the RCC inside into the VSD orifice. And you can see the next slide, that is the with color flow. You can see there is prolapse and there is aortic regurgitation. And whenever there is prolapse of the right coronary cusp, then there is air that impinges the anterior mitral leaflet of the mitral valve. But whenever there is prolapse of the NCC, this is the NCC, then VSD direction will be towards the interventricular septum. So this is the an example of the subpulmonic VSD. When it is called an subpulmonic VSD, when the defect is very near to the pulmonary valve, but there is some muscular tissue attached to the pulmonary valve, that is the subpulmonic VSD. And I am drawing your attention, there is some, many of the times, subpulmonic VSD and doubly committed VSD may do an confusion to you, but there is some, you have to look for the two valve of pulmonary valve and aortic valve. I will show in the next slide. So there is some description of the sub-arterial and doubly committed VSD. What is that? It is characterized by hypoplasia or absence of the infundibular or outlet septum, resulting in fibrous continuity between the aortic valve and pulmonary valves. And this determines that the semilunar valves are at the same level and forms the roof of the defect, and can result in prolapse of the aortic valve cusp with or without aortic regurgitation, more common in person of oriental descent, and color flows immediately below the pulmonary valve and directed towards the RBOT main pulmonary artery. Then what is that? And this is the location of the doubly committed VSD up to the pulmonary valve. I will show the video clip. Then these are one of the things. This is a diagrammatic picture of fibrous skeleton of the heart. You can see there is fibrous continuity between the mitral, tricuspid, and the aortic valve. But pulmonary valve is attached to this fibrous skeleton by muscle skin. But whenever there is doubly committed VSD, you can see in normal valve, the pulmonary valve is located superior to the aortic valve. But whenever there is doubly committed VSD, both the valve will be at the same level. How it looks like, I'll show you. So you can see the doubly committed VSD. This is the video loop. You can see very nicely. This is the pulmonary valve. This is the aortic valve. This is the VSD, and both the valve are at the same level, and there is no tissue in between the two pulmonary and aortic valves. This is the classical example of the doubly committed VSD. I'll show another example of video loop. You can see here both the valves at the same level. It may be, you can see I'm showing you. You can see both the valve at the same level. It's more clear. So this is the VSD. So this is the classical example of the VSD, doubly committed VSD. There is no tissue beneath the pulmonary valve. But regarding the subpulmonic VSD, there will be some tissue beneath the pulmonary valve. And interesting is that you can see if you see the next buccal flow along the doubly committed VSD, this flow goes to the RBOT and directly to the pulmonary valve. Sometimes if you see any continuous Doppler along the pulmonary valve, you may gradient the VSD gradient along the pulmonary valve. So sometimes it may commit and mistakes or confusion that there is pulmonary valvular stenosis. That happens in practical life. But to exclude the confusion, you have to select the 2D images and you have to see the good opening of the pulmonary valve that merges with the wall of the pulmonary valve. Then you can be sure that there is no stenosis in the pulmonary valve. So I'll talk now the inlet VSD. Obviously, the defect that inlet part of the IVS, that is the inlet VSD. Inlet VSD have two types. The inlet muscular VSD bordered entirely by myocardium, and there is muscle tissue beneath the atrioventricular valve. And inlet VSD A-V canal type. There will be no muscle tissue below the atrioventricular valve. Both atrioventricular valve are at the same level. And I'll show it. This is the diagrammatic picture. This is the apical fourth chamber view. You can see this is the inlet, this part when it is involved. That is the inlet muscular VSD. Why? This is the atrioventricular valve and there is some muscle tissue. So this is the inlet muscular. The entire margin is bordered by myocardium. But this is the inlet VSD or A-V canal type because there is no muscle tissue below the A-V valve. So I'll show the picture. This is in Sinalo. You can see the typical picture of the inlet VSD. There is no muscle tissue beneath the A-V valve, and you can see both the leaflets are at the same level, and they are attached at the lower end of the interventricular septum, interatrial septum, or in other words, they are suspended at the lower end of the interatrial septum. So this is the example of the apical fourth chamber view showing the inlet muscular. Whenever you have a confusion, then make an fourth chamber view in crux level. And if you get that there is some deviation of the septal leaflet or offsetting of the septal leaflet of the tricuspid valve, then it is sure that there is some tissue beneath the A-V valve. So this is the muscular tissue. This is the inlet muscular VSD. There is some tissue beneath the A-V valve. This is the example of the inlet muscular VSD. Now about the defect involved in the trabecular muscular part of the IVS. So this is the part that is when it is being affected by any defect, that is the trabecular muscular VSD. You see this is the outlet part and this is the trabecular muscular part. And this is the fourth chamber view. So this is the trabecular muscular part, this is the inlet part. So any defect involving this is the inlet VSD. But this is the trabecular muscular VSD. Now again, the trabecular muscular VSD can be subtypes according to their location inside the trabecular muscular septum. They may be anterior, mid, posterior, at the papillary muscle level, apical level. They may be marginal trabecular muscular VSD. Again, they may be anterior, posterior, central, apical, switches. I will show some examples that will be clarify you. So again, the defects in the muscular septum are frequently multiple and make up 5 to 20% of the defect. And muscular defect may be bilocation, central, apical, marginal, switches septum. Switches septum, that is large number of muscular defect. So I'll show now. This is an example. Short axis view at the parasternal short axis view. This is the papillary muscle level. And I have explained it. This septum can be divided into 3 parts. There is anterior, posterior, middle, and mid and posterior. So for ease of description, any defect that involves this part, you can describe it. There is a defect or VSD involving the mid portion of the trabecular muscular septum at the level of the papillary muscle level. So involving the anterior septum at the level like this. So you have to describe the trabecular muscular septum in this fashion so that surgeon can find out easily, but from your description, where is the location of the VSD. Now it is the example of the marginal VSD. What is mean by any defect that is located when it is the interventricular septum, this is the RV free wall, and it meets with the RV free wall this point. Any defect that occurs this area, that is at the junction of the IVS to RV free wall, that is the part of the marginal VSD. It may be again anterior when it is located anteriorly, and it may be posterior when it is posterior. These are the marginal VSDs, very notorious, very in surgical perspective, very difficult to find out, and very difficult to stitch it. Now switch is defect, muscular defect that may have numerous openings of variable size on the right ventricular side, but only a single opening on the left ventricular side of the septum. This is referred to as the switches defect. But some of the literature, they say that multiple holes or multiple defect involving the trabecular muscular septum, that is also switches defect. So this is an example of the trabecular muscular VSD. And this is another example of the trabecular muscular VSD with sinuous course. And this is the example of the marginal VSD, posterior marginal VSD. You can see the video. It is located at the junction of the IVS and the RV free wall. So this is the color flow. This is the large VSD. So now I'll talk now about the Garvot defect or Jarvot defect. It is located in the membranous portion of the atrioventricular septum. It is a left ventricular to right atrial defect, uncommon, small, echo. It can be seen from an apical approach, angling the transducer anteriorly and superiorly. And so in diagrammatic picture, this is the site of the Garvot defect. And in apical 4th chamber view, this is the defect, location of the defect of Garvot defect. So now I'll talk the traumatic VSD. Occurs most commonly in the muscular septum near the apex, but perimembranous defect have been reported associated with tricuspid valve injury. Multiple traumatic VSDs may also occur, and a direct blow to the chest is the most common mechanism for creating this VSD. So now I'll talk how to evaluate the size of the ventricular septal defect. Very important. So regarding the ventricular size, you have to measure the aortic annulus and the size of the VSD in 2 orthogonal plane. So it is expressed in compared to the size of the aortic root for classifying the size of the VSD, and measurement of the VSD is done by taking maximum diameter in 2 planes that are at 90 degrees to each other. That is orthogonal plane. So depending upon the size, the VSDs may be large VSD, moderate size VSD, small VSDs. So according to these authors, Berles Cruz, there are different literature, different authors. There is some variation, but more or less same. Everyone have use the aortic annulus as the parameter or gold standard, but other author, they have used the body surface. I will show it. The large VSD, if the VSD size is more than aortic annulus. Moderate VSD, if the diameter of the VSD is 50% to 100% of the aortic annulus. Small VSD, that is diameter less than half of the aortic annulus. This is one thought. Another is that the AIMS coaching, they use a large VSD is one that is more than half to 2/3 of the aortic annulus size. And this is the ORAM. I think this is more perfect, but this is cumbersome in clinical practice. It made it according to the body surface area. The large defect that is more than 1.0 square centimeter per square meter body surface area, that is large, and more less than 0.5 is the small. But it is cumbersome in clinical practice. But I think this is the practical in real life. This is the most atoms. Large lesions that approximate the size of the aortic root. Moderate, the lesion is 1/3 to 2/3 of the diameter of the aortic root. Small VSD, less than 1/3 of the aortic root diameter. Pinhole, very small or tiny lesions that is less than 2 millimeter in diameter and detected only by color flow mapping. And this is how to measure the aortic annulus. In systole, you have to make the aortic annulus. Then you have to measure the VSD in one axis, that is the long axis. It is 13. You can see the same patient. The aortic annulus is 22. It is the adult. Here the VSD size 13. And in short axis, it is 29. So it is a very large VSD. More than the aortic annulus. So, and this is another example. The VSD size is 6 in long axis view. VSD size is 10 in short axis view. And this patient have aortic annulus of 10. I have not mentioned it, so it is large VSD. So now I'll talk about the restrictive and unrestrictive type of VSD. What is meant by? Actually, these can be typed as a VSD can be grouped into two categories. This is restrictive and unrestricted. So it is determined by pressure difference between the left ventricle and right ventricle through the VSD. How can it be measured? It is a spectral Doppler. Obviously, continuous wave Doppler is used to determine the velocity across the VSDs and to estimate the gradient between the ventricles. And this is the way you can measure. You can parallel the continuous wave Doppler along the VSD flow, and you will get this spectral image. And you can have measured the peak gradient. Here it is 73. So this VSD is restrictive. This is the continuous wave Doppler cursor. So there are variation or spectrum of restrictiveness. One is the velocity greater than 2.5 can imply that the defect is restrictive. That is, any restrict gradient that is more than 25 millimeter mercury, that is restrictive, but it is in lower range. There are other here. That is moderately restrictive. If the pressure difference is 25 to 60 millimeter and restrictive VSD, RB and PA pressures are lower than the LB with pressure gradient more than 60 millimeter mercury. And restrictive, it is taken from the Echo Manual Washington. The gradient typically more than 75. Actually, we can take it as a 60 millimeter mercury. That is the true restrictive. And another restrictive and non-restrictive, that is depends on the pathophysiology. They have analyzed three variables on the shunt value. Another is the pulmonary to aortic systemic pressure ratio and the direction of the net shunt. Restrictive VSD, it is a small shunt, then there will be shunt less than 1.4, and pulmonary to systemic aortic pressure ratio will be less than 0.3, and there will be net left to right shunt. Moderately restrictive VSD, there will be moderate shunt. The shunt will be 1.4 to 2.2. The pulmonary and aortic ratio will be, pressure ratio will be less than 0.6, and there will be net left to right shunt. Large non-restrictive shunt will be more than 2.2. Pressure ratio between pulmonary and aortic will be more than 0.6, but still there will be left to right shunt. But Eisenmenger's, when there will be shunt less than 1.1 and the pulmonary aortic ratio is 1, that is by pressure in the aorta and pulmonary is same, and there will be net right to left shunt. So now I'll talk about the malalignment. What does it mean by the type of the malalignment? So there is a defect in the alignment that is can occur in between two levels. There may be malalignment between the conal or outlet septum and to the trabecular septum, and there may be malalignment between the interrectal septum and inlet part of the interventricular septum. So a conal septum to trabecular muscular septum malalignment. What is this? The VSDs is characterized by a deviation of the outlet septum in relation to its adjoining trabecular parts. And these have three types. One is the anterior malalignment, another is the posterior malalignment, another is the rotational malalignment. What is meant by anterior malalignment? When the outlet septum appears anterior and anterior to the trabecular septum with the VSD interposed, that is found in top. What is posterior malalignment? When the outlet septum appears posterior to the trabecular septum and it is found in the interrupted aortic arch and severe coarctation. And rotational malalignment is found in toxic being hard defect. It is the doubly committed type defect. DORB. Actually, this is the diagrammatic picture. I don't know what is the value of this drawing. I have made it itself. It is a short axis equivalent of the echo. You can see this is the outlet septum. In natural course, it should come towards this part. You have to meet with the perimembranous part. But instead of coming this direction, this septum has gone in this direction. And this is the anterior direction, and this is the left direction. So whenever there is deviation of the conal septum in the leftward and anteriorly, then is the conal deviation, conal septal deviation. This is the classical example of the top. And if you consider the parasternal long axis view, this is the trabecular muscular septum, this is the outlet septum, and this is the deviation. So there is malalignment between the conal septum and trabecular muscular septum and with VSD interposed. This is the still picture of the parasternal short axis of the classical example of the top. This is the outlet septum. Instead of coming towards this direction, he has gone to this direction. This is the anterior location, anterior direction, this is the left direction. So it is deviated towards the left and anterior. And it makes the RBOT narrow. And there is also pulmonary valvular stenosis. This is another example of the same concept. This is the conal septum deviated towards the left and anterior. And you can see this is the picture. You can see the conal septal deviation. This is the membranous part of the IVS. This is the tricuspid valve, aortic valve, and the pulmonary valve have stenosis. Very good picture depicting the classical picture of the top etiology of failure. And this is the deviation of the conal septum and septum, trabecular muscular septum. If someone consider about the sub-costal view, if this is the sagittal plan axis, sagittal sub-costal view, and we can see this is the trabecular muscular septum. This is the conal septum. In natural course, it has to come to this direction to join with this trabecular muscular septum. But instead of joining this, she is deviated towards this side. And this is the anterior side. So it is moved towards the anterior side. And this is the superior side. So it is deviated towards anteriorly and superior, and making the deviation of the conal septum and the malalignment VSD. So when should one is to use the conoventricular VSD? When one should use the term? Actually, whenever there is malalignment of the conal septum in relation to the trabecular septum, that is the conoventricular VSD. And you can see this is the example of the posterior malalignment of the conal septum. Here the VSD occurs in association with the posterior deviation of the conal septum that often results in sub-aortic obstruction. That is the outlet septum or conal septum deviated towards the posteriorly and cause the sub-aortic obstruction. Now I'll talk about the malalignment between the interrectal septum to the inlet part of the IPS. And this malalignment This malalignment of the posterior septum of the atrial septum relative to the malalignment of portion of the ventricular septum of the atrial septum relative to the interventricular septum, in which case AV valve usually overrides the VSD. It is usually found in AV canal defect. I will show the example that will more clear your concept. So it is the drawing showing it is the alignment between the interventricular septum and interatrial septum. These are the AV valves. And you can see this is the deviation of the trabecular muscular inlet part of the septum or the interventricular septum in relation to the interatrial septum. It is deviated towards the left, so there is malalignment. And this deviation may happen in any direction. It may happen towards the left, towards the right, and there may be deviation of the interatrial septum. These deviation or malalignment, it is classically found in AV canal defect. It may cause the overriding of the AV valve. Overriding means these leaflet may override this VSD, can reach into this opposite VSD. That is overriding. And it may happen at straddling. Straddling means if the caudal attachment have this valve of the left sided valve have caudal attachment of the right side. Now I'll talk about the spontaneous closure of VSD. So the size of the VSD is the single most important variable. Large VSDs are less likely to close spontaneously, while smaller VSD have higher chances of early spontaneous closure. Although more than 50% of large VSDs show a decrease in size in relation to body surface area, only 5 to 10% close completely, and up to 60% of smaller VSDs close completely. And VSDs have a tendency to close spontaneously. This fact is relevant in decision about the operation. And spontaneously closure can be complete by 1 year of age, and the defect may have only narrowed by then, with complete closure taking considerably longer. So these are just some statistics of small VSD. Approximately 70% of small VSD probably close, 25% close spontaneously by 18 months, 15% by 4 months, 75% by 10 years. Sorry, 15% by 4 years, 75% by 10 years. Now, the mechanism of narrowing of the door closure regarding the perimembranous VSD is the narrowing or closure occurs usually by adherence of tricuspid leaflet or caudal tissue to the edges of the VSD. So one mechanism. Another is there for perimembranous VSD, reduplication of the tricuspid valve tissue, addition of the septal leaflet of the around the defect, and prolapse of the aortic valve into the VSD. And small muscular VSD consequence to the proliferation of the endothelial tissue. And this is an example of the closing VSD by septal leaflet of the tricuspid valve, and it's have an aneurysmal shape. And this is another picture of closing VSD by septal leaflet of the tricuspid valve. Now, another mechanism of muscular VSDs that close by ingrowth and hypertrophy of muscle in infants. This is thought to be a continuation of the uterine process of coalescence of sheets of muscle to close the interventricular channels. So aortic regurgitation, how it is happened, a perimembranous defect in an immediate subaortic position or doubly committed VSD may be associated with progressive air that I have shown in previous slide. Now these are the associated defects that may be found with VSD, that is coarctation, ASD, PDA, intracardiac obstruction, subpulmonic, subaortic stenosis, mitral stenosis, like so. Now pathophysiology I'll show on slide. The consequence depends on the size of the VSD and pulmonary vascular resistance. What happens at birth, the PVR is high and there is, if any, left to right shunt, despite the presence of a large defect. But the resistance to flow gradually falls over the first weeks of life, permitting a progressively greater amount of blood to flow through the VSD to RV, to lungs, to LA and LV, And most infants, the LV volume overload causes LVF, leading to increased LV end diastolic pressure, increased LV pressure, and pulmonary congestion. Now, regarding the natural history of the pulmonary vascular disease, it's a very important because for this you have to close the VSD. We want to avoid this pulmonary vascular disease. It is almost exclusively encountered with large VSDs. The incidence of the pulmonary vascular obstructive disease in infants with large VSD is estimated at 10 to 25%. However, it is relatively uncommon for severe pulmonary vascular obstructive disease to occur below the age of 2 years. The associated pulmonary hypertension is generally reversible in the first 12 months of life. Thereafter, it becomes progressively less likely to regress. Infants and children with pulmonary systolic pressure in excess of 50% of the systemic arterial systolic pressure beyond the first year of life are at increased risk for complication. So it is important to remember that the development of pulmonary vascular disease is a tragedy that can be prevented with virtually no mortality by VSD closure. So I'll talk few words about the clinical features now. Now, clinical features, it depends upon the size of VSD, pulmonary vascular resistance, and related complication. So it varies. It may be asymptomatic with murmur. There may be features of the heart failure or features of the Eisenmenger syndromes and others. During childhood, the clinical features are predominantly due to heart failure, and in adulthood, there is features of pulmonary hypertension when predominant. The typical murmur of VSD is rarely heard at birth because the high level of pulmonary vascular resistance causes limitation to VSD flow, though through even an unrestricted VSD, 2 levels are insufficient to provide an audible murmur. And major fall in PVR is accomplished in normal infant within 2 weeks, then the murmur becomes obvious. So for large VSD, congestive failure is an almost inevitable complication of the large VSD, and approximately 80% of infants with large VSD require hospitalization by age of 4, and risk of death with congestive failure is in range of 11%. So thrill at the left lower sternal border is common, and these are the types of murmur according to the size. Large VSD, there is deep crescendo or ejection systolic murmur. Moderate VSD, hollow systolic harsh. Small VSD, the hollow systolic harsh or early systolic ejection systolic type, muscular VSD or muscular VSD. So ECG, it is the interpretation of the hemodynamic effect of the VSD. It causes the chamber enlargement, that is dilatation, with or without hypertrophy, resulting in the change of electrical amplitude reflected in the surface of the ESD. ECG. So reflection of chamber enlargement, there is conduction disturbances and arrhythmia. Small restrictive VSD usually produce small normal tracing of VSD. ECG. For moderate to large VSD, you can have the features of left atrial overload, that is P wave, broad and notched characteristic of the left atrial overload, and deep Q and tall R waves with tall T waves in B5, B6, that evidence of left ventricular volume overload. And this is the picture of the Q, B5, B6, 1, AVL. There is some Katz-Wurzel phenomena. What does it mean? There is biphasic reflection in the limb and the mid precordial limb, that is B2 to B5. It does means that there is combined hypertrophy of the left ventricle and right ventricle and indicate the significant pulmonary hypertension. And ECG is usually normal with RBV with post-VSD closure patients. Now X-ray. X-ray, this is aimed to evaluate the hemodynamic effect of the VSD on heart and pulmonary vasculature. And we have to assess the size of the heart and pulmonary vascular marking. For size of heart, it is the assessment of the size of the different cardiac chambers. The pulmonary vascular marking look for both the central and peripheral portions of the lung field. For small VSD, the normal heart size. Regarding heart size, moderate to large VSDs, cardiac enlargement of varying severity is found. Small for pulmonary vascular marking, small VSD, normal pulmonary vascular markings. But for moderate to large VSDs, increased pulmonary vascular markings in both the central and peripheral portions of the lung fields, and the main pulmonary artery segment is prominent whenever there is no severe pulmonary hypertension. And large VSD or marked elevation of the PVR, marked prominence of the main pulmonary artery and its adjacent vessels with decreased pulmonary vascularity in the outer third of the lung fields. So, in large VSD, the peripheral arterial markings become attenuated and pruned and produced in the outer third of the lung field with markedly increased pulmonary vascular disease. So, this is an X-ray cardiac enlargement, moderate size VSD, cardiac enlargement, and the plethoric lung field. There is increased vascular markings, but this is not conspicuous in this film. And this is the classical feature of the large VSD with failure in interstitial edema. And this is the picture of our Eisenmenger syndrome. Any VSD, that large or moderate VSD that have enlarged VSD, ultimately it shrinks towards the normal size that indicates that there is severe pulmonary hypertension and indicative of Eisenmenger syndrome. And now, echocardiographic findings, I have already talked many of the features of the echocardiographic findings because size, type, size, and restriction, malalignment, all these things are echocardiographically evaluated. So this is the diagnostic test for the VSD. If one asks one test for diagnosis of the VSD, it is the comprehensive echocardiography. So before to complete the echocardiography, you have to make determine the situs of the abdominal organ, whether it is sinusoidus, inversus, ambiguous. You have to make sure the position of the cardiac apex, like whether it is levocardia, mesocardia, dextrocardia. Make sure of the atrioventricular connection, ventricular arterial connection, relationship of the great vessels, and position of the aortic arch. Now, you have to make this checklist for assessment of the VSD with echocardiogram. You have to tell about what are the segments of the IVS that is involved by VSD, what is the size of VSD, border of the VSD, and is septal component, is there a malalignment? There is relation of the cardiac valves and other defect. What is the relation of the atrioventricular valve, caudal attachment to the defect? How many defects are there? And you have to determine the direction and timing of flow by color flow mapping through the VSD. And you have to Doppler align across the VSD to measure the gradient across the VSD that I have talked to. So you have to measure the relationship of the aorta, pulmonarity, aortic valves like this. You have to determine the left and right ventricular size, function, as well as evidence of the RV pressure or volume overload, and associated problem, right, aortic valve dysfunction, regurgitation. Obviously, very important, you have to calculate the pulmonary systolic pressure. How to measure it? You can measure the RV pressure by distracting or the trans-VSD gradient from the arm pressure. You have to find out the arm systolic pressure. Then you have to minus from this the trans-VSD flow gradient. Another estimation, you have to estimate it by tricuspid regurgitation. But between those, regarding these two techniques, you must be sure that there is no aortic stenosis, and in this technique, there is no arbitrary obstruction. So, cardiac catheterization, actually, these are not cardiac catheterization and serine angiograph no longer routinely used in patients with simple VSDs. Now, when surgical intervention is under consideration in older children, cardiac care generally indicated to assess the pulmonary vascular resistance and any associated anomalies, and shows an increase in oxygen saturation at the level of the RV level, reflecting left to right ventricular shunt, and it will get at ventricular level more than 5% oxygen stable. And because low sensitivity of the oxygen, oximetry may fail to detect small VSD whenever there is less than 1, shunt level is less than 1. And helpful in eliminating the possibility of associated PDA or of unsuspected coarctation of the aorta if the arch cannot be well imaged by echocardiography. And if you take the cine angiography, it is the LAO view that is suitable for detection of the perimembranous VSD. For outlet VSD, it is the RAO view. And for the inlet VSD, it is the 45 LAO view with the steep 30 to 40% cranial angulation. So these are the other non-invasive diagnostic methods. These are the magnetic resonance imaging that can be helpful for diagnosing VSD and dynamic 3D echocardiography. And in some cases, for great vessels and pulmonary vasculature, you can use the CT angiogram. So medical management of the VSD, I'll talk very few. So management of the symptomatic infants is directed at improving its symptoms before surgery and buying time while spontaneous closure or diminution in the size occurs. And diuretics for reduction of the preload, angiotensin converting enzyme inhibitors for afterload reduction, and digitalis glycosides can be used. Now the indication and timing of surgery, and this is the timely and rightful application of the knowledge. If you become too late, there will be irreversible pulmonary vascular disease and it will get no help for the patients. So these are the indication of the surgery. These are the characteristics you should consider for surgery. These are the characteristics of the defect, patient's age and symptom, pulmonary vascular resistance, associated cardiac and non-cardiac defect. And these are the guidelines in 2018, the CCI guidelines. That the guidelines, I will not go details to this, it is written in the book, for evaluation or indication of the surgery. But one thing, VSD closure is contraindicated. When VSD closure should not be performed in adults with severe pulmonary hypertension and PH systolic pressure more than 2/3 of the systemic pulmonary vascular and pulmonary vascular resistance more than 2/3 systemic and or net right to left side. And for infancy, these are the characteristics if you were to evaluate. The large and symptomatic VSD should be closed. Medium-sized VSDs associated with failure to thrive. All VSDs associated with aortic incompetence. All inlet or outlet VSDs. Residual VSDs more than 3 mm or those associated with elevated PA pressure. And VSDs irrespective of size if associated another reasons for cardiac surgery. So indication of the surgery, elective surgery is usually performed between 3 and 9 months of age. Now the interventional closure, interventional catheterization for device closure. And these are the trabecular VSD suitable for device closure, mostly those who are located at the basal part of the IVS have proven more amenable to this technique. Straightforward anatomy and muscular rim to which the device can attaches well excellent closure rates with a lower procedural mortality. For perimembranous VSD, a rim of 2 mm between the defect and the aortic valve is required and the patient weight must be more than 8 kg, but some muscular VSD closure devices have been placed in infants as small as 3.2 kg. So I am at the end of my topics. It is the wisdom and knowledge, very favorite slide of mine. Wisdom implies the timely and rightful application of knowledge. Knowledge may even be a pitfall or an encumbrance unless you learn to use it justly. So thank you for your patience hearing.
Thank you, sir. Thank you, sir. It's very nice, sir, informative. Most of the easygoing lecture, sir. This is a tutorial-based class. I think it's a mathematical class, I think so. Thank you, sir, for your, poetic class, romantic class we are hearing from you. Thank you, sir. Dr. Kojaman, sir. Dr. Wadud, sir, please do comment, sir.
You know, listening to this lecture, I was mesmerized. And I was feeling so sorrowful because during my studentship or in initial training period, not have this sort of lecture, this sort of understanding. With the advance of echocardiography of various emerging modalities and more advances in the understanding of the pathophysiology, all these things have become much easier to understand. And Professor Kabiruzzaman has gone through the whole thing with so diligence and has just taken out the gist. Is just taking out honey from hundreds of thousands of flowers, making it 1 teaspoonful of honey. It's like that. And we are really grateful to you, Professor Jamal. We are really grateful.
For your nice compliment. Thank you.
Thank you, sir. I think no question left. I think it's so nicely presented, sir. Chowdhury, sir, please respond.
Can I make a question?
Yes, sir.
Okay, sir.
I think I'm a student.
Okay, sir.
You have not actually talked about what happens even after the VSD closure. We get some patients with certain problems, like persistence of pulmonary hypertension or residual VSD shunt. How do we detect, how do we approach to these patients? Can you talk about that?
Actually, residual VSD, that is talked about that. If it is tiny VSD means the size is less than 2 millimeters, it is acceptable. And provided if there is no significantly increased PA pressure. But in other terms, there are some subsets of patients. They have the ventricular septal defect as well as they have the genetic message for development of the idiopathic pulmonary artery hypertension. These are the subsets that they subsequently develop the severe pulmonary hypertension in spite of timely closure of the VSD or ASD. So for any tiny residual VSD, we can keep it left for follow-up. But one important issue is that you have to be careful about the infective endocarditis and you have to use prophylaxis.
And I think in some of these patients in whom the vaso-occlusive type of pulmonary vascular disease develops, nowadays they are doing some angioplasties in those vessels, plain angioplasties, giving some good effect. Is it so?
Yes. Okay.
Mashkas sir, Chowdhury Mashkas Ahmed sir. You also want to expert, sir? Yes, sir.
I never had the opportunity to praise kabiruzzaman, but in art, I believe he's the only dedicated echocardiographer in the who has dedicated 1 hour after completing his 5 hours course of cardiology. I, in the depth of my heart, had always respect for him. And interventricular septal defect and its location and its numerous name. It has so many names and it has been so confusing for years together. Has made so simplified by this lecture. It made me feeling that I'm just floating within the stars. In the last lecture there was nozzle stump cells lecture, and now another lecture. It makes me so grateful to IPDI, to Professor Wadud and Dr. Mohsin for giving us the opportunity to become astronaut in this pandemic time. I really had a great feelings of moving from start to start through this IPDI, and similar way, the way I was spellbound with Professor nozzle stump cells lecture. Today, kabiruzzaman also has made the same impact on my mind. I'm so grateful to all of you.
Thank you, sir.
Any comments, sir? Mashkas sir, any comment about the VSD for examinee? Professor examinee is hearing. You are the examiner for the examiner board in the I think long case, also short case, also I think the study echo exam. Few comments regarding the exam.
The clinical examination of ventricular septal defect is an important part of clinical examination by the student, because these are being commonly placed in the during the examination, both in long cases and short cases. Also, when they face the viva board and OSP session, everywhere there can be either ECG, X-ray, and the clinical findings. The whole spectrum of clinical variation that occurs along with the hemodynamic change in particular patient should be well appreciated by the patient, and the examiner should be able to make a clean differential diagnosis at each stage of ventricular septal defect that produce specific symptom due to specific hemodynamic alteration to similar hemodynamic changes in other congenital heart disease or in other valvular disease. So they should rationalize their finding with a differential diagnosis which is compatible with the finding that is prevailed in the patient. That is why I wanted to say. Another important thing is that actually what is written in the textbook and what we think that these are in the textbook is not true. I personally, this is my belief that everything that is written in the book can be well delineated clinically, at least clinically. And if we are really very careful about the clinical examination and methodical in clinical examination, many things can be sought out from the clinical examination alone. Thank you very much.
Thank you. Thank you, Professor Emrozul Islam, sir. Sir, you have lots of experience, sir. Yes.
No, thank you. Actually, I just start my grateful thanks. And also, I am really very delighted to hear the presentation of Kobi, whom I like very best. Of course, I also very like Professor Meskat, with whom actually I work, and we share many things about echocardiography. So we have got a few comments. Some comments from Meskat, Professor Meskat. The clinical is very important. We must understand that we are mainly over here are mainly adult cardiology. So adult cardiologists usually mainly want to deal with the goods. And there is two aspects over here. One is the diagnosis, another is the assessment, and to communicate with the surgeons. These 3 points are very important. And for the fellows, one important aspect I want to say is the clinical aspect. In my early days, say in 1980s and 81, when I started echocardiography, and just transformed my experience from just plain mode echocardiography to simple 2D echocardiography. At that time, one of my Japanese mentor told me that, Dr. Islam, you suspect a VSD in echocardiography and then confirm it by auscultation. Possibly this is very important in case of only VSD. If you do not find any VSD, and when you clinically suspect that you have VSD, remember, possibly you are right that there is VSD. So you must go through in different ways. So of course, there are even in modern days of echocardiography, sometimes it is very difficult to diagnose VSD, to classify VSD, to see its pathological sequences as VSD. Starting from our older days, I think Professor Jalal sir is also there. At that time, the only diagnosis were confirmed by angiography, because at that time, echocardiography was not at this level, and we should not go for surgery for only with echocardiography. In that case, only we do an LV-graphy in two view, RAO and LV, as Kabir has said. And that reason, actually, our second cath in ICVD was a biplane echocardiography, where we do it by one shot. So this is one aspect. Another aspect I want to say is the Swiss cheese defect. That is very difficult sometimes to identify, to number it, how many numbers is there. So that is another important aspect. So in this aspect, I actually, I request at least both of them meet Professor Meskat and Professor Kabir. Why don't you start doing 3D echocardiography to supplement our physical, our 2D echo and Doppler echo? So that will be very, very important for us. And we should also be very careful about the atrioventricular septal defect. The term already in different name he has described. And I congratulate Kabir for his hand drawing. It seems very, very important and very nice to look at this end. So it's very good. And another thing as I want to say is about a few things, not about the subject, for the other things. I think we have already reached our cardiologists in Bangladesh at a certain level. We must sub-specialize ourselves. We must have developed some people for goose, some developed for heart failure, some developed for coronary artery disease. Intervention is there. And even then, there should be people who can treat gooch. This is very, very important. I think we have got tremendous large number of younger cardiologists who are very much acceptable to these subspecialties. If you do not use them, if you do not help them grow, possibly they will not grow. At the same time, the country will not grow. So those who are in the middle or in the higher level or older like we people, try to pick up those people and try to develop them, give them opportunity to learn this, so that they can develop, they can carry out the high specialty in upper level. Otherwise, we cannot do that. One man is doing echocardiography, doing cardiography, angioplasty, TAVI, anything. So that is not the way of doing it. So even if our neighboring countries are going in subspecialty of cardiology. So with this, I like to thank everybody, especially the course directors, and of course, Dr. Kobi. Thank you very much, Kobi.
Thank you, sir. Thank you for
We're talking about the gooch blood, our pediatric specialist.
Yeah.
The famous Professor Abdul sir is here. Please, the comments about the gooch.
Thank you very much for selecting me as a panelist. First of all, I like to thanks to Professor.
If I interfere with, I have half a minute. Actually, basically, when I came from Japan and I wanted to start pediatric cardiology, but somewhere or other I could not do that, and that was my one of the spell. So after that, anyway, Professor Salam and I tried to develop a pediatric cardiology with many obstacles. Thank you, Salam. Thank you for this. So I forgot to mention your name as the pioneer pediatric cardiologist of this country. Thank you.
Actually, sir, thank you very much. Professor Nozul sir, Professor Jalal sir is here. They are actually the mentor of me, and I learned many things from them. And they have, both of them actually, particularly Jalal sir was present in my Viva board for selecting as a pediatric cardiologist. I was in fact a pediatrician and having non-invasive pediatric cardiology training from Dhaka Shishu Hospital. And there was a project. So from that I recruited. And after that, I learned many things from Professor Nozul sir, because I was working under him initially up to 1 year of age. Then he has given me the unit as a separate pediatric cardiology, but under supervision of him. So many things I learned from them, and also Professor Wadud and others, Professor Kambul sir, Professor Mohsin, I learned many things. Actually, I'm a pediatric cardiologist by experience, not by education or by any degree. So I am really grateful to all of you, particularly those from NICPD, including all the directors and all the senior professors and colleagues. Next, I like to thanks to Professor Wadud for organizing such a very brilliant platform. IPDI is very essential for learning cardiovascular abnormalities in the day-to-day life. So in this issue of lecture from our legend, Dr. Kabiruzzaman is really a very eminent cardiologist, not only an adult cardiologist, he's versatile on. He knows congenital as well as adult and something else also. So I like to congratulate and thanks for his clear-cut.
Thank you, sir.
Demonstration of VSD. But the thing is, which is absent here, that is the issues of goose. There is grown-up congenital heart disease. What are the issues? What are the solutions in case of grown-up congenital heart disease with VSD? Particularly in that respect, we should comment some things regarding, say, for most of the small VSD, you will not get in after adolescent period. So it will be closed by 10 years. So although we know the small VSD will close, but our issue of talk is today is goose, grown-up congenital heart disease. So there are many cardiac issues, non-cardiac issue, and general issue. So we should address that. And number two is that regarding the cardiac issue of heart disease, VSD, it may be unoperated case with complication or without complication. And it may be operated case with some residual problem or borderline case which are running inoperable or operable case in between. Somewhere they are deferred from the surgical. But important thing is that kabiruzzaman nicely pointed out the location of the VSD, where it is, because it is very important for the surgical aspect point of view, particularly for the incision from which approach, right atrial approach or pulmonary arterial approach or ventricular approach, RBOT approach, which approach the surgeon will approach to the VSD. That is very important. So location is very important. Another thing I want to comment regarding the classification of VSD, it is sometimes confusing for the beginners because you have given a lot of classification. There is a classification given by Van Praag, given by Anderson, given by Kirkling. So the working classification is, I think, it is with the Anderson, and he has given that is the perimembranous, inlet, outlet, and muscular VSD. This simple classification. Then again sub-classification within the kabiruzzaman has nicely described, particularly with the echo, as because he is master in echo. So different view with diagrammatic picture he has nicely described. So for a operator or for a cardiologist, you should understand this different location. One thing is important, that is the anatomy is same, but the viewing or that is the classification is different. Why? So this is a great question. So last 70 years, regarding the nomenclature of congenital heart disease and their segmental analysis, there are variable opinions. The problem is the older the theories have not been cut out or they are discarded. So older theories and newer theories are still present. So there is some confusion. So my final comment is that regarding the issue of GUS, adult or adult congenital heart disease or adolescent congenital heart disease, who should be cared? Because there are many issues, including social issues, pregnancy, contraception. Either pediatric cardiologist will treat or the adult cardiologist. So this subpopulation, for this subpopulation, there is a new idea of GUS or adult congenital heart disease. So this is separate from pediatric cardiology and as well as adult cardiology. So because of unique subset of problems. So we must address those issues when we are seeing a GUS patient with VSD. Thank you very much for giving me the chance. Thank you very much, sir.
Thank you. Thank you. Professor Supriya Raman, Madam, with us. Madam, Professor Supriya Raman.
Assalamualaikum. The presentation was excellent, no doubt about it. He has presented so nicely, so methodically, and as well as demonstrated it, followed by his believing that will definitely help the fellows to see the real life what it is, from the theoretical side to the practical side. And that is a unique presentation, no doubt about it. Thank you very much. I'm proud of you because at one time you trained you, but you are really done very well. And thank you, Dr. Mohsin and Professor Wadud Chowdhury for giving this in COVID era time, everybody, the fellows, nice presentations and taking their time and learning. It is unique. It is helping everybody. And I just was sitting there and wishing, when I was a student, why didn't I have a teacher like this? We didn't have. The Echo has come out, I think, in when we were there in 1978, 79 in UK. Not all the hospitals had it, but gradually the peripheral hospitals got it. So it is a long way they have come. And when we came back, we had to know the echo, to know how to do the implantation of pacemakers and the peripheral angio, congenital angio, then the adult angiogram, all these things. Plus, as you know, that I first introduced the interventional cardiology in Bangladesh. All these, at that time we didn't have any choice. We had to be all-rounder. But Professor Nazrul rightly said, well, this is not the time to be one person to be heavy all-rounder. We didn't have any choice at that time because we didn't have that much of manpower. But you have now, you're so rich with the manpower now, the cardiologists, and we have to see who wants what. And I'm sure, given a chance and train them in the right pathway, giving them their dedication and intention and our guidance, the seniors, and I'm sure they will come up like this, very successful, not only in Bangladesh, all over the world, I'm sure about it. So this is for me, is a great opportunity to see how you have grown, and you have, sometime we used to say Professor Jalal, Professor Nazrul, and still they are sort of, we say podcast. Yeah? Now you are becoming in the podcast. We are below that. We are listening to you. We're learning what is the latest in the cardiology, whether it's non-invasive or invasive. And it's amazing what you people are doing. I know about kabiruzzaman is sometimes when we refer some to surgical side after doing even catheterization, and they say, well, send it to kabiruzzaman, let's have a report, and then see the report and the patient and the catheterization. So that is great. But that is, and we feel proud of you when the surgeons ask for you especially. You know, your forerunners are there. Professor Nazrul is there, and Professor Salam in the pediatric cardiology is there. We have got other in non-invasive cardiology. They are doing very well. Meshkat is also there. So all of you have done in your field and struggled. We had to have not one specialty. We had to take 2 or 3 or maybe sometimes 4. But now is the time, really rightly from the beginning. If you do that and you have got the to guide you, there are a lot of people are there. And Professor, Dr. Mohsin is there, Wadud is there, and the others are also there. I'm sure those who are deciding in the beginning that my interest there. Nobody can force you to do anything. It is your own intention and dedication, and then you will be successful. Thank you so much for letting me say some words, and I wish all of you have a good health and have a good time. Thank you.
Thank you.
Thank you, madam, for your kind words.
Thank you.
Professor Rajagopal is here.
Okay. Before a few comments from the panelists, I to go for one question. Dr. Azizul Haq Sohel, he also registered at Dhaka Medical College, dedicated in echocardiography. Dr. Aziz is a young fellow, plus dedicated on echocardiography. Aziz, put your question. Put your question, please. Yeah.
Sir, assalamu alaikum, sir.
Wa alaikum assalam.
Sir, can you hear me, sir?
Yeah.
Yes.
I'm very fond of Professor kabiruzzaman sir regarding echocardiography. Our Professor Abdul Wadud Chowdhury sir all time ask us to follow Professor kabiruzzaman sir as a dedicated echocardiographer. So I have a question to some question to kabiruzzaman sir. Sir.
Yes.
Sir, can you hear me, sir?
Yes, I can hear you.
Sir, all perimembranous VSD is malaligned or not, sir?
No, all perimembranous VSD is not malaligned. It's an malalignment is a different concept. And perimembranous VSD is the defect regarding the location of the VSD. Actually, malalignment happens whenever there is outlet defect with deviation of the conal septum. This is one concept. Another concept, whenever there is defect in the AV canal part that is inlet part of the interventricular septum with deviation of the either interventricular septum or the interarterial septum. This is the concept of the malalignment in two different locations. Whenever there is conjoint, you know, regarding the outlet septum and trabecular septum, outlet septum developed from the conal crest, and the trabecular septum developed from the primitive interventricular septum. These two septum simultaneously grows and meet with each other. Whenever any deviation between the direction of these two septum, then there is malalignment. This is one section. Another section is that whenever regarding the A-V canal defect, it usually occurs due to endocardial cushion defect. The endocardial cushion gives rise to the atrioventricular part of the interventricular septum. That it includes the primum part of the interarterial septum and inlet part of the interventricular septum. So whenever there is some problem in the primitive interventricular septum, then there occurs some of malalignment. That creates an unbalanced ventricle, overriding of the leaflets like so. So these are two different concepts in two different areas.
Can I add something? It's like that. Whenever you have some problem in the conoseptal part, the outflow tract of the ventricles, if there's any problem in the septum disposition, if it's going up, front or back, there will be malalignment. And very likely, as this concept also contribute in the part of the interventricular septum, there will be a gap. Or in between the tissue, the conal tissue. If there is any problem in there, that's likely to develop into some malalignment if the conal septum is also involved. For malalignment, Professor Kabiruzzaman has beautifully described. You have to have some problem in there as well. And also the problem, interventricular septum is below the atrioventricular valve level, great vessel valve level. So there the main problem is there. And if there is problem above, there is malalignment.
Malalignment happens in two locations. The whenever in outlet location and inlet location.
Inlet location.
So Aziz, you last.
Sir, I have a question. Sir, sometimes during echocardiography, sir, the same VSD is different size in different views. That is, a perimembranous VSD is parasternal long axis view is one size, then a short axis great vessel level is another size. Same VSD. How can we report this, sir?
Hey, you will mention the two orthogonal plane measurement. It's not a circular structure. It is rather an irregular circumscribed structure. Yes. It's a like irregular map. So you have to record the maximum diameter in one plane, and then you take a perpendicular to that plane another measurement. That may be different. Yes. And that is expected. If you say that 10 by 10, then someone will say that you have only
3D echo can say it, exactly. I think so. 3D
actually,
echo.
This is the 3D echo have some limitation. Actually, whenever you do the congenital echo, the small childs or adolescents, they have heart rate, increased heart rate.
Yeah.
And 3D echo needs some frame rate slow. So what is expected is not till today there is not here. So by 2D echo, even if you have the increased heart rate, then you have to decrease the depth of the image and you have to shorten the width of the image. Then you can have a very good image. Okay. But I think 2D echo, if you have a two measurement in two orthogonal planes, that is acceptable. You are not giving you the absolute measurement. Your measurement should be near to the truth. That is enough.
Thank you, sir. Thank you, Aziz. Thank you, Aziz. Yeah, salam sir. Salam sir. Yes, sir.
এটা হচ্ছে কি যেটা অদূর স্যার বললেন যে অ্যাকচুয়ালি এবং আপনি কি মার্ক করেছেন যে স্যার কিন্তু কবিরুজ্জামান স্যার malaligned VSD কোথায় কোথায় পাওয়া যায় সেটা একটা example দিছি। So actually these are only present in case of syndromic baby. আপনার দেখতে হবে বাচ্চাটা syndromic কিনা বা কোনো genetic mutation যেমন ধরেন CAS22 নামে একটা আছে 2211 ক্রোমোজোমের ডিলিশন হয়। এইসব ক্ষেত্রে দেখা যায় যে তাদের কোনো ট্রাঙ্কাল পোর্শনে আপনার অ্যাবনর্মাল গ্রোথ হয় এবং সেটা আপনার কোনার সেপ্টামের আন্ডার ডেভেলপমেন্টের জন্য হতে পারে, আবার এন্ডোকার্ডিয়াল কুশনের সমস্যার জন্য হতে পারে। এখানে এমব্রিওলজিক্যালি তিনটা জিনিস আছে, এটা হলো এন্ডোকার্ডিয়াল কুশন, মেসোডার্মাল টিস্যু এবং নিউরাল ক্রেস্ট সেল। এই জিনিসগুলোর সাথে জেনেটিক এবং ক্রোমোজোমাল অ্যাবনর্মালিটি অ্যাসোসিয়েটেড থাকে। Whenever you are getting a baby with malalignment VSD, তখন আপনি সিনড্রোম গুলো আছে কিনা ওই পেশেন্টের ভিতরে ফিজিক্যাল ক্যারেক্টারিস্টিকের মধ্যে, ফেসিসের মধ্যে এগুলো খেয়াল করবেন। আর সিম্পল ইয়েটা যেটা হচ্ছে যে স্টার্লিং বা ওভাররাইডিং স্টার্লিং এর কারণেও কিন্তু একটা ম্যালালাইনমেন্ট ভিএসডি হতে পারে। হ্যাঁ, সেখানে আপনার সিনড্রোমিক ফেসিস নাও থাকতে পারে বা জেনেটিক মিউটেশন নাও থাকতে পারে। ইউজুয়ালি দ্যাট কোনো ট্রাঙ্কাল ম্যালফরমেশনের যেসব ক্ষেত্রে হয়, হেমাটোলজি অফ ফ্যালট, ডিওআরবি, টিজিএ, হ্যাঁ, এইসব ইউনিভেন্ট্রিকুলার হার্ট, হ্যাঁ, এইসব ক্ষেত্রে ইউজুয়ালি ম্যালালাইন ভিএসডি থাকে।
Thank you, sir. Our foreign faculty, Dr. Sarwari Anjal Dasgopal, please give comment. Yes, he's from Malaysia. Yeah, please unmute yourself. Sir, please unmute. Okay, sir.
Thank you for the nice and complete presentation. It was very straightforward and very clear. Just one question that I would like to ask is, do these congenital VSDs accompanied by any conduction defects? Do they have any conduction problems or defects?
Yeah, go ahead, sir.
The question.
Yes, there may be conduction defect. But I have not gone through elaborately to these topics. Actually, whenever there is involvement of the cracks of the heart, you know, all the conducting tissue travel from aorta, atrium to ventricle below at the level of the cracks. So there may be a conduction defect. There may be conduction. Even after surgery, even after surgery, if there is chance of... Okay.
Salam, sir.
Mohsin.
Okay, Salam sir want to say something.
Thank you.
As shown partially by Dr. kabiruzzaman, that is the right ventricular surface of the interventricular septum. So there is a septomarginal band, three things. One is infundibular septum from above, which is dividing the pulmonary anteriorly and aorta posteriorly, and the on the septal wall, that is the septomarginal band having anterior limb and posterior limb, and above is ventricular infundibular fold. This triangular area, and above that area there is a pos area. So from the pos triangle, the atrioventricular bundle, that is every bundle start, and then it bundle of which then divide at the crest of the IVS into that is the right and left bundle branch. So the extension of the VSD, when it is posterior inlet VSD, it is very crucial for the surgeon to take the bite. They may engulf the bundle of his during their biting, so the patient will develop conduction defect. Not only for the surgeon, this is also important for the interventionist. During implantation of the VSD device, they may also develop heart block. Another is the ventricular infundibular fold. If any surgeon or rupture that area or give incision to that area, he will go outside of the heart. That is the transverse sinus. So these are the very surgical point of view. In view of surgical importance, kabiruzzaman should send that slide also. Why it is important to approach by the surgeon to avoid the conduction tissue injury. But the outlet VSD, there is
conduction defect in VSD.
Posterior muscular extension VSD have the maximum chance of conduction tissue injury, either by surgery or by intervention.
Thank you. Wadud sir, comments on the conduction defect in VSD.
Conduction defect actually depends upon two things. Whether there is a coronal tissue involvement, and this type of tissue involvement actually are more related to conduction type defects, and particularly with syndromes. And again, iatrogenic. I also want to talk about the acquired VSDs, the ventricular septal rupture that we have after MI. And this can be ameliorated either by surgery or by intervention. And in our country also, they have done one successful ventricular septal rupture closure by device. I think Prof. Mohsin has done that, is he? I do think so. And the traumatic VSD, we are not very accustomed to it, but this happens particularly when driving. If there is sudden stoppage due to an accident, car-to-car head-on collision, the pressure of the steering wheel on the chest, that may lead to VSD. How come? If the particular moment of impact, if the valves are closed, the outflow tract valves are closed, there is a great force generated within the heart, but the valves are closed. The septal rupture can occur. And these ruptures are usually very sinusoidal, and these are very problematic. We have one patient who had an accident in Russia, one Bangladeshi student who was there. He had frank heart failure, came back to the country. We drive him up with IV infusion to a risky angio. Find the LV showed that the tortuous sinusoidal VSD septal rupture, and the operation was done. And he later went back to Russia, married a girl there, and living still quite well. We have a published report of that. These are rare cases that can happen. Traumatic VSDs and traumatic during operational conduction defects realities that surgeon has to take very much care, and Salam sir has pointed out in which particular area the incision or intervention is going to likely to develop in conduction defect.
Thank you.
Actually, whenever there is a VSD repair by incision of the ventricle, then post-VSD right ventricular conduction defect is very common. So to avoid this, many of the surgeon tries to the atrial approach. This is only I could have that slides, but I have removed that to make it.
It's for the fellows. It's not that important. It's mainly more important for the surgeons.
Yes.
Thank you, sir. Professor Mohammad Jalaluddin sir with us. Sir, few comments regarding class. I think it's the last comment today. Okay. Professor Jalaluddin sir, please unmute, sir.
Okay.
Sir, unmute finding, sir. Unmute করেন, sir.
স্যারকে একটু বলে দেন বাম দিকে
নিচে বোধহয় আছে দেখুন স্যার।
হ্যাঁ, ওই জায়গায় ক্লিক করতে হবে স্যার। স্যার বাম দিকে নিচে
স্যার
ওখানে পিকচার আছে স্যার, ওটা ক্লিক করতে হবে।
I'm trying, but
single touch. No, it's not.
স্যার স্ক্রিনের নিচে বাম দিকে দেখেন স্যার মাইক্রোফোন পিকচার আছে।
স্যারের নাতি বোধ না আজকে নাতি।
ওকে স্যার, it's all right.
Okay sir.
Okay.
Yes sir.
Thank you very much for asking me to say something. I like to say a little bit about the age of echocardiography in Bangladesh. In 1969, I had little training in echocardiography in Vienna.
69 sir or 79 sir?
Sorry, 1979. Then I came back. After coming back, I joined NICVD. Then we had a contact with Japan. Then we got the one echocardiography machine that is 2D and MR and black and white. First of all, I took that the echo machine to see something. Then I put the transducer in the machine, and I found that the heart is moving in a black and white echocardiography. And I saw the valves and the chambers of the heart only, moving heart and moving chamber. And I called my other fellows, other colleagues, to see the echocardiography. They were taking it as magic, that how a torch-like substance putting on the chest, the heart can be seen moving, the valves can be seen, and the chambers can be seen. At that time, we could only diagnose very little things, the mitral stenosis, mitral aortic stenosis, but regurgitation could not be easily detected because without color flow, regurgitation cannot be seen. That was the beginning of echocardiography in Bangladesh. Now it is 2020, about 38 years. Now, at that time, what was echocardiography? And today, what in the last two lectures, Professor Kabiruzzaman, how he has described how much development the echocardiography is now at this moment. And also, at that time, Professor Nazrul Islam came in NICVD. Professor Abu Jafar was also in the beginning of my senior, very close, very respected colleague, Professor Abu Jafar. Also, he was doing the echocardiography, and Professor Nazrul Islam came in NICVD, and he has also taken some lesson and the training from Professor Abu Jafar. And Professor Nazrul Islam also has raised the standard of echocardiography in NICVD. He is doing many cases. I think he is the student teacher of many of the echocardiographer at this moment in Bangladesh. And he has today described the relation of the clinical aspect as well as the echocardiographic relation of the VSD. And Professor Salam also described the VSD, the role of echocardiography in many ways, and especially the malalignment, kabiruzzaman, as well as Professor Salam was taking. And Professor Meshkat was also saying about the relation of echocardiography and the clinical aspect of the VSD. And these are the things has been well described. And Professor Kabiruzzaman described the VSD in such a way, in how many ways the VSD can be described. I think he has described everything. How many classifications are there? And what happens in the beginning of VSD and what happens afterwards, VSD, if it is not intervened. So, Kabiruzzaman has described the VSD in such a way that he can give the clue to the surgeons how to operate this patient, how to be successful after the operation. Thank you, Professor Kabiruzzaman, for your nice deliberation and elaborate deliberation about the VSD. Thank you very much. And thank you. Thanks to Professor Mohsin and Professor Abdul Wadud Chowdhury to arrange this session. Thank you very much once again.
Thank you, sir. Every fellow should know the journey of echocardiography in Bangladesh. Thank you, sir. I think it is the archive, so everybody know after I think past coming years. Thank you, sir. Dr. Arif Sajal. Any? I think everything discussed. No chat question in the left in the chat box.
Almost all the questions have been discussed, sir. Okay. So I think you can continue, sir.
Thank you, Arif. Yes, madam.
আচ্ছা আমি জিজ্ঞেস করি মেশকাপকে যেগুলোকে অ্যান্সার দিতে পারে কার্ডিয়াক ক্যাপ করার পরে সার্জনরা কেন বলে যে মানে ও এই কালের গুড কার্ডিয়াক ইকোকার্ডিওগ্রাফিস্ট নো ডাউট অ্যাবাউট ইট কেন বলে যে ওর কাছে যেতে আমি জানি বাট আই ওয়ান্ট টু নো ফ্রম ইউ why they do it, why they do ask for it.
Meshkat sir, please unmute.
ম্যাডাম এটা খুব ভালো একটা কোশ্চেন করছেন, কারণ আমরা we never had been that dedicated echocardiographer. আমাদের কবিরুজ্জামান ও 1 বছরের ট্রেনিং করে এসেছে, and he has paid all his attention towards the congenital heart disease. কিছুটা সে নিজেকে দাবি করে হাইব্রিড কার্ডিওলজিস্ট হিসেবে, কারণ পিডিয়াট্রিক প্র্যাকটিস এত সুন্দর।
You're right.
Surgeons always required a clear roadmap before they go for surgery. কারণ ক্রস টাইমটা খুব অল্প, ওই অল্প সময়ের মধ্যে they do not have time to search out for any other lesion. The lesion has to be very well described before the surgery is being done. তো সেই জন্য এমন একজনকে দরকার যে এই ম্যাপটা খুব ভালো করে দিতে পারে। আমরা ম্যাডাম কবিরের মতো হতে পারি না, যার জন্য হচ্ছে কি কবিরের উপরেই সবাই নির্ভর করে।
না আপনিও এক্সপার্ট।
আপনিও এক্সপার্ট, ইউ আর নট লেস দ্যান এনিবডি এলস।
না আমি তা বলছি না ম্যাডাম।
এই কোশ্চেনটা যদি another আপনার শুনতেছে, if there is an intelligent fellow they will pick up this question and now and again হয়তো বলতে পারে যে কেন। you are right absolutely, কারণ
না ম্যাডাম আমি
কার্ডিও ক্যাথ বলেন আপনি।
না আমি বলতেছিলাম ম্যাডাম আমি না, এটা হলো সত্যি কথা, কারণ এটাতে যদি ট্রেনিং লাগে স্যার, ডেডিকেশন লাগে। আমি কনজেনিটাল হার্ট ডিজিজের কথা বলতেছি ম্যাডাম। আরো অনেকগুলো অ্যাসপেক্ট আছে, যেমন ধরেন অ্যাডভান্স ইকো, ট্রান্সিসভেজিয়াল, স্ট্রেস ইকো, ভাস্কুলার ইকো, ওগুলোতে হয়তো আমরা কিছুটা ভালো, কিন্তু এর বেলায় যে ডিটেইলিংটা লাগে সেটাতে ডেডিকেশনটা হয় না তো ম্যাডাম। সেই ডেডিকেশনটা আমাদের আমার বিচারে ম্যাডাম। আর নিশ্চয়ই আমাদের পেডিয়াট্রিশিয়ান অনেক ভালো করে, পেডিয়াট্রিক কার্ডিওলজিস্ট নিশ্চয়ই তারা আলাদা। কিন্তু
my point is
মহসিনকে, ডক্টর মহসিন এবং অদূর চৌধুরীকে বলতে পারি, আপনারা যদি একর উপরে এরকম 2-3 জনকে নিয়ে করেন, টাইমটা ডিভাইড করে, তাহলে আমার মনে হয় ভালো হবে। ডিফারেন্ট অ্যাসপেক্ট একদিনে যদি হয়, আজকে যেমন আমি বললাম একটা কথা খেয়াল করছেন কিনা, যে আমি যদি স্টুডেন্ট তাহলে এটা শুনতাম, তাহলে ভিএসডি যে কনফিউশন গুলা মোটেও থাকতো না। তো এটাই এত সুন্দর করে আজকে প্রেজেন্টেশন হয়েছে। এটা হলো যে সার্জনরা চাওয়ার কারণ যদি কার্ডিয়াক ক্যাথ করা হয়, ইট শোজ where is the VSD, it shows but it doesn't show the actual how many are there, number one, and whether these are repairable or not. Not all muscular one you can repair. So there are big ones which you can repair, but the small ones you can sometimes you have to leave to close by itself. The surgeons prefers to know where they should go for it, but after putting in the patient in the table, you can look for the defects. But if you see it from before, it is easier for them to identify, because once they are under the anesthesia, it is very difficult to find the VSD. So that's why they prefer to see it in the echo, where and how many are there, which one is big, where is it, and where if they do it, will there be any problem, any leftover consequences or not. That's why. But done the echo, we don't need catheterization. So there is a compliment for you, and now my request to Mohsin and Dr. Wadud as well, please find something that have a little bit of congenital. I'm sure you will be able to do it. Under your good guidance, it will be done.
Thank you.
We should.
Wadud sir, please. Wadud sir, please. Already passed lots of times. Please. Complete the session. Yeah.
I think we have had a very beautiful session, and we have had beautiful discussion as well, and also some historical perspective about the development of pediatric cardiology and also the echocardiography in this country. One thing is that when we were learning, our teachers were not that expert on that particular field, because that has come, those particular subjects has come into this country at the same time. They were learning, and we were learning after them. Now our teachers level has come to certain level. Now we can try, as Madam has already suggested, we should now go for branching into specialties. Our young generation should go for that. They should be specialized on a particular topic. They should be a master, not like jack of all trades. They should be master of a particular context. That will be doing a very good service to this country. And to that end, this lecture series and everything we do is for this motherland. আমার বঙ্গবন্ধুর সোনার বাংলা যে স্বপ্ন উনি দেখেছিলেন, আমরা দেখছি, আমাদের বর্তমান প্রধানমন্ত্রী দেখছেন, আমাদের এখানে যারা আছেন পায়োনিয়ার ইন্টারভেনশন কার্ডিওলজিস্ট, পায়োনিয়ার কার্ডিওলজিস্ট, আমার জালাল স্যার, সব টিচারদের টিচার, আমাদের এখানে পায়োনিয়ার পেডিয়াট্রিক কার্ডিওলজিস্ট, সব পায়োনিয়ার। তার মানে কি, আমরা সবাই আসলে শুরু করছি মাত্র। We are not that big, our history is not that long, but we can go ahead, and the future lies with the youngsters. They should forge much more, and we will be giving the blessings. We are becoming much older now, and our teachers have become much older. We need to have good service, good care of ourselves from you. You should become top-notch cardiologists of whom we can become really proud. I do think you will become like that. With that end, with good day, afternoon to everybody, and wish all of you stay safe, stay active, and keep in touch.
Thank you, sir. As Professor Subero Madam says, 160 million people in Bangladesh, only less than 10 good echocardiography in Bangladesh. I think it is, we are trying to enrich our junior fellows. I think fellows are so much delighted and enlightened to this lecture. Also, Professor Jalal sir, Subero comments, producer comments, also Sarwai Ranjan Rajgopal and Chaudhry Bashkar Ahmed sir. Thank you, sir, being with us. And Incepta Pharmaceuticals being given the job for last 4 months with us. Thank you, Mizan, Shodop, and Adnan others. Thank you to Pradipurman Shajol, Professor Abdul Wadud Chowdhury sir. Thank you, sir. Our next class on 30th August, Sunday, at same time, 3:30 p.m. Our budding cardiologist, my younger brother, Professor Abdul Mohsin. He also, I think, dedicated echocardiographer. He will talk on ASD, another good ASD topic. Till then, goodbye. Allah Hafiz. Stay safe and take care, sir.
Thank you.
Assalamu alaikum.
Assalamu alaikum.